Thank you, Jackie. That was amazing. So beautiful pictures, so incredibly, they look so easy to read. I bet I would never be able to see any of that if you were not presented. It's so great. Our next speaker is Dr. Baby Lanford. I thought it was Laura, but yeah, I skipped. I was wanted to CT directly, of course. Dr. Lanford is Associate Professor of Pediatrics here at Children's Hospital of Pittsburgh and University of Pittsburgh. And she is a very senior advanced imager. And she'll be talking about aortic valve echocardiography. Libby.
Thank you. Good morning, and thank you to the team for allowing me to show some hopefully pretty pictures. I'm going to start off with looking at the 2D imaging of a normal aortic root, and this is a picture taken from one of Professor Anderson's prior talks. And you can see that this parasternal long axis is just a slightly rotated version of that. And you can see the aortic valve leaflets, the sinuses, the mitral valve, and as we've learned, the muscular component and the fibrous continuity between the mitral valve and the aortic valve. And we'll just let that play. So again, aortic valve leaflets, what we in the echo world would call the annulus, the sinuses, sinotubular ridge, mitral valve, muscular portion of below the aortic valve, and then the fibrous portion. Looking at the trileaflet aortic valve, looking at the individual leaflets, this is an anatomical presentation, and this is the echo presentation, which is a anterior, posterior, right, left. This is a short axis view, and here is your pulmonary valve, and you can see how the commissures line up between the aortic and pulmonary valve, and in echo we call this the rightward, leftward, and then the non, which faces the atrial septum. And as we watch it play, you see a trileaflet aortic valve. Leaflets move well, no evidence of abnormal thickening. We do look for the coronary. So again, this is the right coronary sinus. This is a parasternal short axis view, and you can see the 2D image of the right coronary. And you can see over here, we've tilted a little bit to see the left coronary coming off the leftward facing sinus, and the last one would be the non-coronary sinus. As Spice discussed, right, we call this an aortic valve annulus. In the echo world, as you can see, there is no fibrous ring there, but this is what we measure at the hinge points of the aortic valve leaflets, the sinuses, and then the sinotubular ridge. So standard measurements that we do on everybody. So now we're going to look at some abnormal ones. This was a patient with critical aortic stenosis and unicuspid, and I'm sorry, this was a very small valve. It's very hard sometimes to actually see the leaflet morphology when the valve is only 2 or 3 millimeters in size. So these are actually still frames to show you. This is with the aortic valve closed. You get this little circle at 6 o'clock, which is what we talked about. That is, I've never seen it be anyplace else. So that helps me decide whether it's a unicuspid valve, the location. And then as you see it open, it again is this very small opening. To give you a better sense, this was the same infant. It was a critical aortic stenosis. So this is now looking at the arch. So here is your aortic valve and the sinuses. And as you let it play, you'll see that this little tiny red jet is the only flow going across the aortic valve. That is the only antegrade flow across that unicuspid aortic valve. And again, it's also going to be posterior because that is where that orifice will be. And this blue flow in the arch is all coming from the duct. So this was a unicuspid valve with critical aortic stenosis. But not all unicuspid valves have to be stenotic. So here is an example of a unicuspid aortic valve that works really quite well. And again, you can see that that commissure point, where it all comes together, is down here at around 6 o'clock. But this one opens quite well. So again, leaflet morphology does not always determine the physiology. This is that same patient, looking at it from a parasternal long axis view. One of the things that jumps out to me when I look at this, if I can stop it, not in the right place, sorry. is that when we watch it play, I made it mad, there's this additional attachment to the sinotubular ridge, which you don't usually see in echo. And that, I mean, the leaflets come up to the sinotubular ridge, but there isn't this extra attachment, and that usually is a sign that the valve is not going to function normally. And again, as you look, you can see that this aortic insufficiency that comes through this unicuspid valve is again in that very posterior location. But again, this is just trivial AI and really not much aortic stenosis, so no intervention has been needed on this patient with unicuspid aortic valve. The much more common things that we see are the bicuspid aortic valves. And as we've already sort of intimated earlier in today's talk, there's really sort of two patterns that we see. We see, again, this is a parasternal short axis view, aortic valve, pulmonary valve. So the sinuses facing the pulmonary valve will be the right and the left, and the other one is the non. So here is a right and non, and when it opens, you can see here is that raphe. So it has wide opening, but it opens vertically. We don't get what we refer to as the Mercedes sign in the trileaflet one that opens normally. So here is that same patient, and you can see that the area of insufficiency is right along that area of the commissures. So this would be a right and non. The other common version is the right and left. And when it opens, so here is your opening, you can see that there are two leaflets, but they are fused, and that this opening is angled this direction. And as we watch it play, again, this is the opening from a right and left fusion. We do have one of these two. So here, this is a patient with a quadricuspid aortic valve. This is not a truncal patient. So here's a blow up the still frame of the four cusps. Here is it partially opened, and you can get a hint that there is a pulmonary valve, so I'm not cheating and showing a truncal valve. I think we only have one of these that I know of. And here's the valve fully opened. And as we watch it play, here are your four leaflets of a quadricuspid aortic valve. This patient has mild central AI from this, but again, has not required any intervention. And this is just sort of a nomenclature question. I don't know if, Diane, whether you guys have addressed this, right? So that it's easy to identify the right and the left coronary sinuses are in the proper place. It's sort of like the non has now become two. So it's sort of like non-1 and non-2 sinus. Anyway, we don't see this very often, so it's not too much of a problem. And then there also can be a trifoliate valve, 3 leaflets, but the leaflets themselves are abnormal. So again, you can see the 3 leaflets opening, but very thickened leaflets, and a suggestion of an orifice in the middle where there may be some AI. So moving on to other parts of the left ventricular outflow tract and how they interact. Subaortic membranes are fairly common, so we can see it arising from this muscular septum. And things that I notice when I look at this, you certainly see that membrane, which remember is really going to be a 3D surface. I sort of think of it as like a crescent-shaped or a crescent moon going all the way, potentially all the way around the LVOT. But if you look at this anterior leaflet, you can see that it's fluttering. It's being hit by an abnormal jet, and this is probably part of the reason you can develop AI. If you also look at this mitral valve, the continuity, the fibrous continuity between the aortic valve and the anterior leaflet is here. This valve is hinging here, it's bending here, which would make me suspect that that leaflet, that membrane goes all the way around onto the anterior leaflet of the mitral valve. You can't really see it by 2D echo, but you can suspect it. And again, that makes it a little bit harder to resect because you don't want to end up with a hole in the anterior leaflet of the mitral valve. And here is just color with that, and you can see that there is already evidence of AI directed posteriorly, suggesting that the origin is from that abnormal motion of the anterior leaflet. Here is one of our examples of supravalvular aortic stenosis. This is a TE picture, so this is sort of equivalent to that parasternal long axis view. These are all still frames. I'm going to start with this one because I think it shows the hourglass deformity the best. You know, here is your aortic valve, here are your sinuses, here is the narrow sinotubular ridge, and here is the ascending aorta. So as we watch as the valve opens, it looks to me like the leaflets are actually hitting that sinotubular ridge. You see the tips of the leaflets are coming all the way up to that sinotubular ridge. And when the leaflets actually get fully open, they actually have to bend backwards. You see how they sort of pull up, they're sort of bending because there's no room. And then that's causing injury to the tips of the leaflets, and when it closes, you can sort of see this sort of dysplastic-looking tips of the leaflets. And as we watch it, this is the clip that came from. I get the feeling like that's one of the things I look for with supravalvular aortic stenosis is that hitting of that sinotubular ridge. The other thing I will say from an echo perspective is this one is fairly obvious. There's a lot of subtle supravalvular AS out there, and it's really important to try to always measure that sinotubular junction, which is hard by echo, but multiple views in a patient with LV outflow tract obstruction, because it really does affect your surgical management. And I think it's one of the things that is easily missed. And then this patient, this is a beautiful example with color across that LV outflow tract. You can see the AI, but what's most important was what you can see is that the annulus is here. There isn't flow acceleration at the annulus. The flow acceleration occurs at the sinotubular ridge. So this area is what needs to be enlarged. And again, the coronaries are obviously involved. We cannot diagnose coronary osteostenosis yet by 2D echo in the presence of supravalvular AS. Just always suspect it. And we can see whether Dr. Oliveira thinks we can do it by CT yet. We also just spend a lot on angiography for that still and for surgeon inspection. The other abnormality is also true, that you can have an abnormally dilated sinotubular ridge, which also causes problems with the leaflets. And here's an example of a patient with Marfan syndrome, and you can see this. Here's the annulus, here's the sinuses. I don't even know where to measure the sinotubular junction. We just sort of measure it, but it's all dilated. I know this is a Marfan's patients because you can see the evidence of mitral valve prolapse. But we also see this in our switches, the neo-aortic root, when the pulmonary root is moved over, and we also can see it a lot, unfortunately, in our hypoplastic left heart syndrome patients who also have a neo-aortic root where things become dilated. So as I said, you can see that we've attempted to measure a sinotubular junction, but really that narrowing is gone. And with this dilation, you start to see aortic insufficiency because the leaflets are beginning to be pulled apart. They don't coapt well. And again, just showing how the aortic valve leaflets aren't the only thing that matters, right? The whole structure below and above the leaflets are important for the functioning of this LV outflow tract. And this is an en face view of the three leaflets. So the leaflets themselves look beautiful, but we're beginning to see central and actually a little bit of eccentric aortic insufficiency. I had to look it up. My grandmother used to make them. People sometimes talk about this as the clover leaf sign, the clover leaf rolls, about how the three sections of the roll as your aortic sinuses become dilated in honor of Thanksgiving. So now I'm going to move on to an example of one of our surgical patients. And this is a 3-day-old who had the concern for coarct, so I think it was probably a suspicion prenatally. This is the apical 4-chamber view. You're going to see that the right side is big, which is what you would expect with coarctation in an infant. The LV looks a little small without measurements. You don't know whether the LV is abnormally small. See an aortic valve. The LV outflow tract looks widely patent, just small. When we put color on, there's no flow disturbance in the LV outflow tract. There's no narrowing of that color jet to suggest narrowing. And then there's a small perimembranous VSD with left to right shunting. Here is the parasternal long axis view. I apologize, it's kind of a little jumpy, the playback, but you can see here is the aortic valve, the sinuses, the sinotubular junction, all of that looks well formed. You can see there's no focal narrowing in the LV outflow tract. So we did measure, and in this case, the aortic valve annulus was 5 millimeters, which was a z-score of -3.2 for this baby. The root was -2, and the sinotubular junction was -3.2. Ultimately, this infant went on to have a coarctation repair as a neonate. Unfortunately, then had recoarctation that was ballooned. But once the arch obstruction was relieved, there really was no LV outflow tract gradient or obstruction. And then at 9 months of age, this child got another follow-up echo, and now the LV outflow tract is looking very abnormal. It's hard to tell on this. You can see there's an aortic valve here. You get a hint of some muscle going in and out, and there's also a tiny membrane. We look with color. The color can help you because the AI here is coming from the aortic valve annulus, so I know the annulus is here. So this is subaortic stenosis, and the sinotubular ridge does not look very large in this picture either. So just that, these are actually hard to see. So I took still frames from that prior clip. So when you angle your probe, you can see that there is this muscle that protrudes into the LVOT. This is a 9-month-old. In this frame, this measured about 4 millimeters. So very narrow from that muscular protrusion into the LVOT. And then if you tilted the probe just a little bit differently, so remember it's a tube of LV outflow tract, it's a 3D surface, and we're showing it in 2D. So here you can see that there is also a membrane in a slightly different plane. And we did our Z-scores again. And what was interesting to me about this child is the aortic valve grew a little bit, but it never had catch-up growth. The Z here was still minus 2.5. So hypoplastic, and this was a child who had recoarctation, so had high pressure in the LV. If anything, you would think would make that grow. The root was acceptable, and the sinotubular junction was only minus 1.6, but I'm not so sure I really believe that based on the images that we got. This is not the ideal example, but I did want to point out that I really love the subcostal sagittal or subcostal two-chamber view in infants and toddlers to get a whole look at the aortic valve, ascending aorta, aortic valve, aortic root, ascending aorta. You can get all the way along the length, and I just think it's important to remember in this population. We've picked up supravalvular AS from aortic cannulation sites. We've found a lot of things, and it's only really seen in this view, if you have a child small enough. These didn't show up very well, but when they focused on the aortic root, they got a gradient of about 45-50. When they focused more up in the ascending aorta, they got gradients that were more 70 to 80, raising the concern from an echo perspective of supravalvular AS that we're not really seeing very well by 2D. All right, so this child went to the OR at 11 months of age, and this is a transgastric view, which shows you the LA, which is dilated, the mitral valve, the LV, and this very sort of tortuous, narrow LV outflow tract with lots of tissue in there that wasn't there when this baby was born. We've shown you pictures, and so it is acquired. I don't know if we have any arguments about why some infants do this and others don't. So this is that muscular area, this is that subaortic membrane, and then this is the aortic valve. Sorry, my mouse is now acting up. Come on, mouse. All right, so this is about a 120 view by TEE. Child was asleep, so it wasn't a moving target anymore. And this is similar pictures to a parasternal long axis view. So you can see here the aortic valve. Here you can see the muscular sub-AS. What's also a little bit interesting to me, you can see this tendon here, which actually goes across and attaches to one of the papillary muscles, but I don't think is attached to the mitral valve. And I just don't know how common this is because we earlier this week did a complex LV outflow tract obstruction, and the child had exactly that same tendon. So it's not really contributing to the obstruction, but it's not a normal structure. When we put color on this outflow tract, you can see that here is the annulus. You can see that there's flow acceleration proximal to that. You can see how narrow the color jet is, showing you that there's multiple levels of left ventricular outflow tract obstruction. just to verify, we actually had suspected this on the newborn echo, but this child actually has a tri-leaflet aortic valve. And the leaflets themselves look okay. Again, the annular size is hypoplastic. And despite all of this that's been going on, there was just trivial central aortic insufficiency. So based on our imaging preoperatively, we had thought that there was tunnel muscular subaortic stenosis, there was subaortic membrane, there was a hypoplastic aortic valve annulus, and we were suspicious there might be some problems in the higher up in the ascending aorta. And the operative findings showed tunnel-like LVOT with subaortic membrane, tri-leaflet aortic valve, supravalvular aortic stenosis. So again, showing problems with sort of all levels of the aortic root. So I'm still amazed. Here is the picture post-op, the same picture we had before, because I have it up here to show you. So this is what we had pre-op. Here is what it looked like in the OR post-surgery. Anterior leaflet of the mitral valve. This LV outflow tract is now widely patent. We don't see any of the muscle anymore. I forgot to mention, sorry, it was a Roscono. And here was the aortic valve. And when we look with color, LV outflow tract widely patent, no evidence of any focal narrowing anymore, no evidence of aortic insufficiency on this particular view. And this is our most recent echo on the same patient, which is only a month ago. She is now 13 months old. And you can see that the LV outflow tract is widely patent. You can see it's subtle, but here is the hinge point of the anterior leaf of the mitral valve, and because this is a ROS, there is some infundibular tissue underneath here, and so the aortic valve, the neo-aortic valve does sit a little bit higher, which makes measuring those roots a little bit hard sometimes. And then here, they were trying to sweep in, but you can sort of get a hint that the aortic root now is quite large, and there's no residual supravalvular aortic narrowing. And now all of her Z-scores are well above -2. They're dilated, and the sinotubal junction measured about a Z-score of 1+2. Thank you.